Dear doctors, this is Dr. Sherrier from Shares Medical Academy. As you can see, we have a topic. Its name is cardiology, especially hypertension. So we are going to discuss this part in our coming section. Stay with us. Now, as you can see, there are definitely some learning objectives for hypertension, especially the outlines from John Murtagh. If I tell you guys, you know, you need to learn the causes, also the normal ranges, and you will find all those things in, 969 of John Murtagh. Ambulatory blood pressure measurement is given in 937 of John Murtagh. So these all are 7th edition page numbers. Cuff size, again, it is mentioned 972 John Murtagh, and antihypertensive drugs, names, and certain other things. So this is another important stuff here. All right, so you need to know, and especially some special conditions like, say, hypertension with asthma, hypertension pregnancy, hypertension, renal artery stenosis. These all are some of the important topic to learn. Also from antihypertensive, also the basic management of antihypertensive drugs, the side effects, their names, the classification, the contraindication, mechanism of action, no need. Okay, hypertensive, some emergency conditions, especially nitroprusside, hydrolazine, the drug name, and especially mild to moderate or severe, you need to decide that one. And the second thing, what is the drug of choice that you need to know. Finally, that hypertension with pregnancy. Okay, you need to follow whatever I will tell you in that particular time. So let's go and hit our class at this point, as you can see. Okay, so thanks for joining. As I mentioned, so this is the topic list, as we can see. Now, getting into John Murtagh, just want to see if my things are working well. Yeah. Now, this is the chapter we're looking for, John Murtagh, 7th edition. The page number is 969, and 6th edition user, please follow 955. Okay, now talking about few things, the causes. So for this one, we need to take a whiteboard, definitely. And if we can see in the whiteboard, we have to learn, the causes of hypertension, which is a very basic thing. Okay, so the causes of hypertension. This is the main topic. Now, it's also divided in this way, that's primary, sometimes it is told primary, and otherwise called secondary. The primary is much more common, it's almost 90%, which is also known as the essential hypertension. You can, if you want, you can write, this is also known as essential hypertension, right? Like, someone who is developing hypertension, maybe the cause is not known, maybe it's familial, all these things. So this goes with this one, the primary one. Now there's a secondary cause, like say example, if there's a kidney problem that can lead to hypertension, like example, say renal, artery, say stenosis. Okay, so these particular things are, I can say, like, a secondary cause of hypertension in some heart condition, like coarctation of aorta. So there's certain cause out there that can lead to hypertension, Cushing syndrome that can lead to hypertension. This is certain other things. Let's see some of the causes which can lead to secondary hypertension. Before we jump into the cause of hypertension, here is your normal ranges are given. As you can see, these are the normal ranges. You can just see one time. Why? Just to understand in the main exam that which is normal and which one is not, right? So this is important. And This is also mentioned essential hypertension. You just need to know primary as hypertension and mostly the essential. And causes of hypertension, essential of the primary is 90 to 95%. And of course, there are a lot of secondary causes of hypertension, under them kidney, under them endocrine, under them coarctation of the aorta, under them the drug is one of them, can lead to hypertension, can come in question, especially steroid to remember. Also NSAIDs to remember. Sometimes they ask tricky question, like they might mix up things, and they might ask you what could be the cause. So if an NSAID is hidden there, that can also lead to hypertension. Okay, and pregnancy, and a lot of pregnancies, like especially 1/3 of the pregnancy, sometime there's a rule, like if a pregnant woman develops hypertension, 1/3 of the cases, it will persist. 1/3, it can be more bad. 1/3, it will be resolved totally. So there's some rule of 1/3 rule, it is said. But anyways, like after the ranges and all this thing, we just go through what are the secondary cause of hypertension, how this question can be tested. They might mix things, you need to understand, or they might ask you, what could be the cause of the hypertension. Then according to the lab, according to the scenario, you will tell that okay, this is the cause of the hypertension. This is a I would say a nice to know topic. Okay, just to learn causes. All right. Now, in the next page is 970. If you can see, a big chart is given. Factor influencing hypertension. Yes, family is a big part, but apart from that one, stress is so important. So there was a question like that. Patient was presenting with hypertension. Should you start drug? When you were taking the history, there were a few things. The patient was a bit stressed out these days. He was having exam, or he was having, a breakup and all these things. So he's stressed out, and so should we start the drug? The answer is no. We don't start the drug. Okay, so we'll do some consecutive follow up, and then to be sure, like you all know, 3 consecutive occasion you need to find the blood pressure is elevated more than 40, 140 in systolic and more than 90 in diastolic, in order to tell that one as hypertension. So sometimes there's a lot of things are written here. Sometimes they might ask you a question as well, which one of the following is correct and which one of the following is incorrect. So that time this kind of question would be useful, but still this particular thing I would say is a nice to know box again. So moving forward, like secondary hypertension, as you can see, this box can be useful for all of you guys. Like say, if they want to make a question with renal artery stenosis, how they will make it. They'll give you some features of renal artery stenosis, like palpable kidney, or the palatable kidney, better to say. And there could be some abnormal renal sound, which is called renal bruit. And patient develops hypertension, and creatinine level would be high up. So the lab and the clinical scenario, and your diagnosis is renal artery stenosis or the hypertension. That's how the question can come, right? So you need to remember this particular thing. And so please just highlight 1 to these points, could be useful for all of you. Renal artery stenosis, again, we will teach you guys in the kidney section. So don't worry about the renal artery stenosis. It is a high yield topic for hypertension. Not hypertension is mainly renal topic. So moving forward, secondary cause of hypertension. Now, the question that is actually so important and a tested topic, and it's also mentioned in handbook in the beginning pages, that if someone presented with hypertension, what is the next thing you should see? So sometimes I compare and contrast. What does it mean? I'm coming to that point, compare and contrast. Your cuff size measurement, we need to check. Small babies coming or with underage, you find the pressure is high. You at least need to check the cuff size, and also you can check the hypertension in different poses, different positions. Okay, so this is one of the tip to remember. Secondly, compare and contrast. I was talking, what does it mean? Compare and contrast, that means that the similar kind of thing happens in what case? Like say, if in renal you find urine RMA is abnormal, so what to do next? You'll straightforward, you give the drug. No, we still like to recheck that one. So repeating the urine RMA, it is so important. So sometimes a option is used. Its name is clean catch urine. I repeat, its name could be clean catch urine. All right, so clean catch urine in case of urine RME that particular thing if comes some pus cell or some abnormalities. And if they offer you clean catch, that means maybe the urine while they were collecting, it was not, that well, it was collected, because you need to know that sterile container, mid-stem urine, those are required, but sometimes it does not happen. The patient might collect the first half of the urine, it could be contaminated with the, nearby skin. So this thing we need to remember here, okay? Like, so this kind of thing, this is how, if you remember, we call it compare and contrast, right? Now, there's few other things: white coat hypertension, refractory white coat hypertension. When a patient is in the hospital and they see the doctor, the blood pressure is bit raised up. So you need to consider that one. Mine, this is a nice to know topic. Now, ambulatory 24-hour BP monitoring, like say, if you think the patient might have hypertension and if you are not sure, but you also can't leave the patient in that way. So in that case, you can go for 24-hour ambulatory BP measurement, and what other indication is are given here. So there was a relevant question from ambulatory BP monitoring, so you need to learn this chart actually. Ambulatory 24-hour monitoring. More popular one, again, compare and contrast. 24-hour Holter monitoring, that is actually so important for exam. Like, say a patient presented with syncope, or patient is sudden unconscious, recurrent syncope, especially recurrent syncope, recurrent dizziness, and all these things happening in a patient, and might have a pre-existing cardiac problem or arrhythmic related problem, or you suspect an arrhythmic problem, you definitely should go for that particular thing, that 24-hour Holter monitoring is important. Okay. Again, the basic things are given, and hypertension you should start checking from the age of 18, and you should check every 2 yearly. You should check every 2 yearly, but if it is borderline, in that case, check in 1 yearly. This is important. So sometimes question might come as screening. For Aboriginal people, it can be a little different. So this is mainly for the general adults. Some drug might be a cause for hypertension, especially steroid and NSAID to remember. But still, you should also understand some simple nasal decongestant can also lead to hypertension if you use for so long time. Now, this is especially is important for MC clinical, like special findings and all these things. But you can just check this thing one time. Okay, hypertensive retinopathy, guys. Hypertensive retinopathy will teach you guys in eye. We need to see the slides and all these things. So we'll be teaching this particular in the stages of hypertensive retinopathy. This is, important. So hypertensive, retinopathy, we will be going to teach you in the ophthalmology section. Like, you need to know which are hemorrhagic cases. So these are hemorrhagic cases, cotton and wool exudate. So this kind of thing you need to understand. Okay, so this is another one. Cryo, central retinal artery occlusion, central retinal veil occlusion. So these are the particular finding we need to learn for fundoscopy, and these are the grading. So tortuous CT, when there is hemorrhage, when it is even more severe, especially if there is papilloedema, it is even more severe. So we'll teach you that one when ophthalmology would be there. But now I'm just telling you that superficial thing, like, that's, we can say, just trailer. The main movie is coming after some days, when you'll be in the ophthalmologic science. Now, let's go back again. Okay, so we're going through this one. Especially we're going towards now a spatial thing. There's a pharmacological therapy. It's 978, as you can see, guys. Okay, a very basic thing to start it with, guys. I hope you are using the pen and paper. The very basic thing here is the age group less than 55. The drug of choice is often ACE inhibitor. More than 55, often the drug of choice is a diuretics. Please remember this basic. I repeat, less than 55, we always like to use ACE inhibitor or the ARB, all these things. More than 55, we might go for that typical diuretics. This is a very basic thing, nice guideline. Many other guidelines, if you even see the Davidson, I was think they are following this one. And this is important. So strategy of medication, you will see inhibitor names, also in dietitian name, but main parameter is the age group. Now, also certain other comorbid condition. What does it mean, comorbid condition? Say someone is having asthma. Now, what is drug of choice? Someone is having um, some other issues, heart block and all this thing. Now, which one is a choice? So that's how you also need to consider before giving a drug. Now, in this place, certain names of the drug like diuretics name are given, beta blocker name are given, calcium, ACE, ARB, these names are given. You need to understand one thing, that basic difference between ACE and ARB is still similar, but with ACE inhibitor they might have dry cough because of there is in relation with the bradykinin. Okay, so that's why ACE inhibitor might start it with dry cough. So that's why maybe some cases ARB better, but in between them still the guideline we follow, we always started with ACE inhibitor still. But all patient is developing dry cough. If the dry cough develops, then it's better to switch ARB. You can definitely read the renin, angiotensin, and aldosterone system from physiology, or you can go to YouTube and learn that one little bit. For MC, typical that renin, angiotensin, and aldosterone, typically we don't need it actually. But for more interest, you can see that one. All doctors should know that particular renin, angiotensin, aldosterone system. Now, in this chart, sometime I like because initially the names are given. Now, for whom it is recommended. Now, you see a calcium channel blocker is recommended in asthma, right? Sometimes a beta blocker like labetalol is recommended in pregnancy. Of course, alpha methyl dopa is one of the choice of drug. I'll tell you that one very soon. All right, and some contraindication definitely, like see beta blocker, asthma name is given, so it's a contraindication. We need to remember, like ACE inhibitor, if the patient is having pre-existing hyperkalemia, you better should not give that one, or if it develops hyperkalemia. So it is very important with ACE inhibitor or ARB, you keep checking the potassium level after certain time. Another thing, if you see ACE inhibitor, it is also contraindicated in bilateral renal artery stenosis. The reason behind this is when you use this as ACE inhibitor, it causes the renal arteries, those things, vasoconstriction. So artery stenosis is already it is constricted. So if you give that drug, that can be even more fatal, right? So that's why you remember now precautions are a nice thing given, has certain drugs. So this particular thing you just need to memorize. And some important side effect like diuretics, if you can remember, we used to remember all hypo. Few things are hyper. That's why we remember. So hypokalemia, hyponatremia, and few hyper like hyperuricemia. This is a very important thing. I can even tell you. Along back, my mom developed um, like she had hypertension and she was taking drug and suddenly she was complaining of joint pain and all this thing. The doctors was very simple, they were giving NSAID, so but it was not going, so I was that time fourth year student, so I hit the book and I was going through book, I found it that one. So later I realized she was taking a drug name. Its name is indapamide, which is a diuretic. So because of the diuretics, which is a very good drug, for her, but it also develops hyperuricemia. So when I mentioned that one to tell the doctor she's attending, because I was in a different city, so she went to the doctor. The doctor was happy. Okay, oh yeah, okay. I think yes, it is right. That drug is causing it. So you see, this is a standard maneuver you guys should remember. Remember one thing: all antihypertensive drug can lead to hypotension-related problem, but some of the drugs causes it even more. Like you can see, um, diuretics can cause ACE inhibitor. This particular thing can cause, the postural drop and all these things. Okay, so you should remember that diuretics one of the leading from the front, but all of them can cause postural drop. Especially if you use in combination two drugs, even more higher chances. If you use an anti-depressant drug and anti-hypertensive, even more chance patient will develop syncope and all these things, right? Now here's few weird things are given. Following combination useful. Okay, you can check. Yes, often we saw this combination is used. But remember one thing: if you use thiazide, if you use SE, if you use an NSAID, that can be a deadly combination. So never use thiazide, never SE and NSAIDs all together. Kidney will have a bigger problem. Now we have a nice line. Thiazide is good first line therapy for hypertension. Yes, but better to say when more than 55, below 55, better we think with ACE inhibitor and also other comorbid factors. Now with these particular things, maybe you can read a little bit of yourself, see renin-angiotensin receptor system, where ACE inhibitor working, where ARB is working, you can read it once. Hypertensive emergencies. Now, this is a topic which is tested in MC. So we had the hypertensive emergency, how this question can be tested. Let's take the whiteboard. Okay, first of all, it's an emergency and it will be given in the question 220 by 180. That's how it will be given, or even could be malignant hypertension, all these things. So your primary idea to make this blood pressure down. So how to do that? So if it is coming with this hypertension to the emergency room, it is extremely high. So we might call it severe. Okay, in that case, what we need to do, we need to give a certain very powerful drug to reduce all this hypertension and all these things, right? So in this case, so some of the drug of sodium, nitroprusside, there are drugs like hydralazine, there are drugs like labetalol, and so others, the drug name. Let's see some drug names like initially and later. So sodium nitroprusside is a good drug. Also, if someone is pregnant and develops, very high um, this hypertension, all these things, especially second trimester, it can be pre-eclampsia things or eclampsia things. So you need to also consider that particular thing. Okay, so the pregnancy one we are coming. One of our topic is this. So hypertensive emergency we are going through right now. So in the emergency cases, how it can be presented? The two-way one, the patient came for routine antenatal checkup. The same thing they will tell you in AMC exam. Routine antenatal checkup, if they say it in that way, so and you get to know there is maybe mild hypertension. Definitely directly we might not give the drug, we might follow up, but if develops later mild, confirmed second visit, third visit, that if it's a permanent hypertension or maybe essential hypertension, or maybe she never knew that she was having hypertension. So anyways, mild to moderate case, mild to moderate cases of hypertension, antenatal checkup, which is related to pregnancy. So now we are at that point, that hypertension with the pregnancy. This is the most important thing. So you need to follow my lecture, whatever saying. So mild to moderate, we'll have to go with alpha methyl dopa. This is the drug of choice. But if it is severe like 220 by 180, now what to do in that case? In that case, we definitely like to go with uh, anyone? Yes, that is beta blocker. Labetalol is one of the popular drug. Labetalol. This is one of the very important. So mild to moderate alpha methyl dopa, severe cases beta blocker, that labetalol. Like talking about the hypertension. But if it's malignant, if it is an emergency and all these things, you can definitely go with hydralazine and all these things. All right, but usual cases, so this mild and maybe moderate or just severe, we control with the labetalol. These are the popular two drug of choice. Okay, some people ask me, doctor, which one is first line then in between them? See, in UK system, because since I teach both, in UK NICE guideline and all this thing, they talk about the labetalol as a drug of choice. In Australian, lot of system and things, alpha methyl dopa, it is mentioned. John Murtagh we have also seen, but I come to in summary, because according to the question, mild to moderate cases, it is better you go with the alpha methyl dopa. If it is the moderate to severe, a bit higher patient present to emergency, if that's how it is presented, you go for the labetalol. So these are the particular things you need to know for this hypertension. And yes, there is a spatial chart coming up. Spatial chart, let me show you that one. A very spatial chart. Yes, so this is page number 984 for 7th edition user, 6th edition user 970. So these are the some of the page numbers, right? These are some of the page numbers. So this is very interesting. You guys, I think, probably will be more interested on this one. Okay, so let's just try to see this one, how it probably looks like. So super high yield, Um, Now, what are the points that has been tested? I'm going to tell you. You mark these things, guys. AMC, it is tested. With heart failure, it is tested. Mm, Next, yes, with pregnancy, definitely it is tested. Um, with Raynaud's, guys, Raynaud's, I will teach you in rheumatology. Okay, don't worry. There are certain important questions with Raynaud's. Yes, renal artery stenosis, which will be also taught in renal system. It is also tested. And yes, kidney failure one also tested. So along with these particular conditions, you need to remember. See, I'm sure all of you know that beta blocker is something to be avoided in case of asthma. Beta blocker probably we also don't like to use in diabetes. Okay, so these are the conditions you need to remember. Now, what is the drug of choice if it's asthma? Now, you can go for especially diuretics or calcium channel blockers. So these are the some of the drug of choice depending on other comorbid condition. This is important. Cardiac failure cases definitely, you remember from the last day, if it is acute case, acute heart failure, you never use beta blocker because why? It will decrease the contractility of the heart. Next thing that's coming, the diuretics and the AC you need to remember. So diuretics if acute symptom present, AC inhibitor if stable patient. How do you know it is acute symptom? Patient will have cough, patient will have dyspnea, patient will might have dependent edema. So left heart failure feature, which is affecting the lung, pulmonary vasculature, there is increased hydrostatic pressure, pulmonary vascular pressure is increased and patient is having cough, uh, dyspnea, basal creep, gallop, and all these things can be present, the acute symptom. In that case, we like to go with the diuretics, okay? Very, very important. Patient, if ever develop hypertension, and okay, so this is also tested, this is a handbook question. Okay, so in this case, hypertension, because of the drug, so you immediately stop the drug and switch to some other. So even in case of my mom, it was switched to AC inhibitor later. Okay, sorry, ARB later. She was switched to ARB. Now she's fine after that. With pregnancy, I just taught you guys alpha methyl-dopa or labetalol, depending on mild to moderate or severe. Mild to moderate, go for alpha methyl-dopa. Severe cases, go for labetalol. Renal artery, since it is coming again and again, it's better I tell you guys this one. Renal artery. So in case of this renal artery stenosis, just one page. Sometime I came up with this one type of one page things. So in this one page thing, renal artery stenosis, where is the problem? Kidney is the problem. If kidney has problem, your creatinine level will be raised. So that's how we remember. If creatinine level raised, someday the patient might have toxic feature. What is the toxic feature? Uremia is the toxic feature, right? So their kidney is failing. Uremia feature develops means your kidney is really failing. Now, renal artery stenosis, how it can be presented. Now, this box is taken from Davidson. Definitely, this is one of the causes of hypertension or secondary hypertension. Important clinical finding, the kidneys will be palatable bilaterally. Most of the renal artery stenosis are bilateral. There is a test, it is called if you give AC inhibitor and if renal function will be deteriorating, that's for sure, but we usually don't do that. Okay, it is like the DVT, there is a sign like compare contrast. I'm telling is if there is a Homan sign, if you just just bend the leg and cuff and all this thing, and patient have pain, so that is the indicator that Homan is present. But we usually don't do that. Why? The thrombus in the calf muscle can be dislodged, so we don't do Homan sign if you suspect. But usually it's also indicator, so same that kind of indicator where someone has did it and they find it positive, so that's how it came. So kidney asymmetry, bilateral kidney can be so asymmetry of the kidney will find because of the pressure difference. Now they might ask you the renal artery stenosis and all this thing, how renal artery stenosis is presented. So in renal artery stenosis, okay guys, remember one thing, due to pressure difference, kidney size and asymmetry can happen. Don't confuse it. There's another condition, polycystic kidney disease, where both kidneys are extremely enlarged and palatable. That's a little different. But here, palatable is not the correct word. It's asymmetry because of the pressure difference. All right, renal artery stenosis. If it is given, now this is so important for MC. If it is bilateral, I repeat, if it is bilateral, in that case, the answer should be diuretics. SE, we never give, it is contraindicated in bilateral renal artery stenosis. I will repeat it again. Bilateral renal artery stenosis, we never give diuretics. This is so important. What about the unilateral renal artery stenosis? Unilateral renal artery stenosis, we go for a very interesting SE inhibitor. Now, this is not big problem. Um, so SE inhibitor unilateral, we can go with SE inhibitor. Okay. So renal artery stenosis unilateral SC, bilateral diuretics. This is the extra important thing to learn. I'm holding it here so that you guys can go through this one page note for one thing. I hope so you'll appreciate this note and all this thing I've just told. So before we left, let's go back to our chart. What we learned, causes we learned, ambulatory blood pressure measurement curve, antihypertensive drug side effect and all these things, that particular table. Hypertensive emergency is this one, and hypertension with pregnancy. Okay, the thing I just talked in the lecture, mild to moderate and the severe and some emergency cases. I hope so you enjoyed this part. All right, guys. So I hope so you enjoyed, and don't forget to subscribe to our YouTube. And that's all for today. So thank you so much, dear doctors. Have a good day. This is Dr. Sherrier. For any inquiries and all this thing, or if any of your friend interested in AMC, we are a very trustable organization. So thank you so much for your recommendation and all these things. So this is our number. They can always message us or call us. Thank you.